Hang on, there's a few people hopping in. Hang on one second.
Okay.
All right, I think you're good.
Okay. Hello, everyone. So we're going to do GI board review today. And there's another one just based on how the schedule was set up in a couple of weeks on nephrology. I have done that test. Whitney is typing that one out. Dr. Holloman is gracious enough to do that board review. And that will be, I think, at an 8 o'clock on a Tuesday in a couple of weeks. So when we finish this one, you'll have another one put up soon. So please do that one also. So today we're going to do GI. And let me just go ahead and say there's one question coming up where on the test it was typed wrong. My fault, not Whitney's fault. My fault, not Whitney's fault. My fault, not Whitney's fault. She forced me to say that. Okay.
Thank you so much.
You're welcome. So when that comes up, just take that under account. And again, it was just as I went through it and just didn't catch the answer that was actually mislabeled. But anyway, all right, so the first one, most of you got that. This is classically, she's 5. Remember the C. diff under 1, but she's 5. She's been on amoxicillin. This would be straightforward in the fact that what you would do first, now hold on, here's a beep. Is that somebody? She's headed down. Okay, this is Becca Widener about the med student thing. Okay, I hope she knows where she's going. Anyhow, okay. So it's pretty straightforward there. If you miss this one, you really need to go back because that's got all the earmarks of a C. diff infection set up. Number 2, previously healthy. Now this is who has fever and persistent vomiting, and the emesis was clear. Now it's become bile stained and contains bright red blood. And so the most likely cause of hematemesis, what would be, he's vomited, it's bad. And now he's got this bright red blood. So the answer there would be a Mallory-Weiss tear. That's somebody who vomits a whole lot and has a Mallory-Weiss tear. Now, for him out of the blue to have peptic ulcer disease, esophageal varices, gastric duplication, esophagitis could be a potential problem for you. I got that. But the fact that his vomiting has become bile stained is kind of giving you a sense of the severity of the vomiting. To be vomiting bile, there's something bad going on in that GI tract. I mean, he's vomiting with a lot of gusto. And so that's going to set you up for a Mallory-Weiss tear. Number 3 of the following statements that you are most likely to make concerning the mechanism of action. Well, you just have to understand pharmacology and how that works. Remember, this particular medication is a barrier. It's a barrier medication. It's a coder. It's not an H2 blocker. It's not an H1 blocker. It's a coder. So here it's creating a barrier against hydrogen ion diffusion. I mean, that would be what that particular medicine is all about. Okay, number 4. And oh, by the way, Whitney is handling questions for me. So if you put in the chat or have a question, Whitney is doing it and she'll relay that to me. Number 4 is an 8-month-old, poor weight gain, voracious appetite, but has frequent malodorous stools. So of the following, what would be the most likely diagnostic test to help you with the malabsorption? Well, you could play the game. Is he malabsorbing carbohydrates? Is he malabsorbing fat? Is he malabsorbing protein? Is he malabsorbing vitamins? Or is he malabsorbing minerals? I mean, when you see malabsorption, those are the 5 ticket items that you go through. I don't think there's anyone who malabsorbs water, for example. So you think through that. And in these questions that were here, thinking through the malodorous stools kind of puts you into the fat, and then the fecal fat would be the appropriate diagnosis. You could get caught a little bit had they had serum ADEK. Now, if they were really tricky there and didn't put fecal fat, that's where it's a part C question. In other words, you have to say, okay, this is fat, but fat's connected with fat-soluble vitamins. My fat-soluble vitamins are A, D, E, and K, and therefore the answer might be a prothrombin. See how that works? You see how you connect, that they're doing that a lot. You have to be able to connect dots here, that it's not necessarily going to be straightforward. This is pretty straightforward. I'm not sure I even know what stool, milk, and soy precipitates are. The stools for eosinophils, once again, Not so sure. It's for the leukocytes, but once again, the malabsorption is not, leukocytes are going to be for inflammatory, infectious. Now, I understand that you can absorb within the confines of an infectious or inflammatory disease. I got that. But if it's just looking for malabsorption with the word malodorous, that's kind of the giveaway. That's going to be a fecal fat. Number 5, 16-year-olds concerned about deterioration in school, behavioral change. Well, you know, this is a GI test. If you didn't know it was a GI test, that sort of opening sentence could be all over the place, right? I mean, you would have to think about drug use. You could think about that he's got a CNS issue, et cetera, et cetera. Now, here's a question. They say he denies substance abuse. Okay, you have to buy that. I know in reality, clinical practice, that doesn't necessarily hold, but on a test, when they say that to you, unless they're going to qualify it with something akin to, he denies substance abuse, but he has been arrested in the past for marijuana. You know, if they say something like that, then you can interpret the fact that substance abuse might not be true. But when they do something like this, they just make that declarative statement, you take it. And it's so he's not on drugs. The hepatomegaly, now you really start association, behavior change, hepatomegaly with a GI test. I mean, it should almost have you falling out of a tree. What's the diagnosis? Wilson's disease, hence what you're going to do, ceruloplasmin, okay? The ammonia, what's missing? If you're going to do an ammonia classically in the stem of the question is vomiting. They're going to have vomiting for you to get a hyperammonemic syndrome. Therefore, order a serum ammonia, okay? Fasting blood glucose, I'm not sure about diabetes. There's nothing that goes there. Alpha-1 antitrypsin, okay. You could have liver disease with alpha-1 antitrypsin, but now you've got to get the school performance going, as opposed to, well, you know, he looks jaundiced, or he, you know, his stomach hurts or something like that. So going through all this, the answer is ceruloplasmin. Number 6, 12-year-old UC. Well, you just have to know what is the most likely problem in any patient with UC. It's sclerosing cholangitis. That's what they get. And of course, when they set you up with that question because of the jaundice. So in other words, that's the trick, that you're having sclerosing cholangitis, you're getting jaundice from a outflow tract of the liver problem, right? Flow tract problem. So that should be a direct hyperbiliary if it comes to that, as opposed to an indirect, but they don't ask you that. Just throw that in for free, okay? All right, number 7, 10-year-old developmental delay, regurgitates. Basically, I don't know how many missed this, but you know, you probably with this developmental delay, which is very important here, the abdominal muscles. If you don't know this, you might have tried to buy into Sanderford syndrome, right? Now, here's the deal. When you see something like gastroesophageal reflux, in the same manner of an answer with Sanderford syndrome, does Sanderford syndrome incorporate GE reflux? Do you see how those two would not be the right answer, just because how would you tease out one from the other? So the answer is the rumination syndrome. This is a classic, what we call ruminator. And remember, it comes from cows who chew their cud. Remember, they have 4 stomachs, the cows, it goes in, it comes back up, and they chew, and it goes in another stomach, etc. So that's where the word ruminator comes from. And this is the rumination syndrome. And again, it has to occur in patients who have developmental delays, and they have a calming effect. So it's kind of like trichotillomania. If you pull your hair, why do people have that? They're generally anxious, and there's cutters. Why do adolescents cut themselves? It's a calming effect for the anxiety or the pain, whatever they're going through. So a lot of these are manifestations of kids who have anxiety or underlying developmental disorders, such as in the stem of this question. Okay. Number 8, 14-year-old with JIA. Now, this is the one that's misanswered on the test. So just don't, just understand that if you look at that. Basically, if you go through this, the setup is she has severe pain. She's taking ibuprofen, okay. She's in distress, we got that. She's got tenderness in the epigastrum without rebound, okay. So, you know, they're not trying to say she's got peritonitis, but she does have some stool that's positive. It's dark, so that's going to be upper GI pathology relative to blood, as opposed to lower, where they would say bright red. White count's not really impressive. Hemoglobin, well, you know, she's probably menstruating. They don't tell you that. So we might say that she might be a little low on that. We would like a 12, but she's got some blood. That's fine. Her SED rate is up a little bit, which goes with JIA, and her other numbers are normal. What is the mechanism for her symptoms? Well, basically, this question does come down to the wrong answer, but if you said that, I can understand it, because the right answer is the inhibition of prostaglandin synthesis, because that's how ibuprofen works, right? And that's how you can get a gastritis, and you can have the pain, and now the upper tract and whatnot. The reason this answer, for those of you who put duodenal stress, isn't a bad answer, because with JIA, you can get a duodenal ulcer as part of that disease potentially. But I think that the trick here is when they say stress your ulceration, it kind of puts you into, had they said medication, had they said something else to help you with a duodenal ulcer, that would have put you more into that. So the most likely would be E. So this question represents, once again, getting it down to 2. Now, if you put C, D, or A, those are really not reputable answers for this question. But I can see if you put B, don't beat yourself up. But I think of most likely it's just going to be the ibuprofen. Duodenal ulcers are pretty rare. Okay. All right. Number 9, 7-month-old edema, iron deficiency, hypoproteinemia. And if you saw that, if you started there and didn't look down, you might say, well, what is the diagnosis going to be? Okay. And so this could easily be kwashiorkor, right? Your brain should have thought that reading that first sentence. It could be another intestinal problem, intestinal parasitic problem, for example. So there are a lot of things there that could fit with this particular opening, but they help you with everything was fine until he started eating non-breast milk, ergo gluten. So what is the answer going to be? C, gluten sensitivity, a celiac disease, right? The giveaway here is that infectious enteropathy could potentially be there, like I say, parasitic disease. But let me tell you, if I were going there, I would, with this presentation of iron deficiency hyperproteinemia, I would want the stem to be just derived from Africa, just derived from Haiti. You know what I'm saying? I would need a stem to put me into this patient having that. And then the negate, I would have to then negate, they're telling me about the wheat and the oatmeal. You just can't negate the wheat and the oatmeal, especially when the answer of celiac disease is there. Okay, so that's the answer. Number 10, jaundice. You've got to know your jaundice. I mean, I'm telling you, you've got to go age-related jaundices. You've got to know your direct versus your indirect jaundices. If they're going for Crigler-Najjar or Roeder or Dubin-Johnson, probably not the right answer because they are so rare. But they are expecting you to know basic blood group incompatibilities, biliary atresia, galactosemia, hypothyroid, because those are things that you're going to see. All right. So I just going into a test immediately in my brain, if I'm going to see something weird, that's not the right answer for a Gen Peds test. It might be the right answer for a GI board fellowship test. You see, and again, I'm just saying on par. I'm not saying it can't be, but I'm just saying on par. Okay, so here we go, jaundice. It's conjugated or unconjugated, unconjugated. There's no blood group incompatibility. You buy that. So it's not an ABO-RH incompatibility. And the peripheral smear is normal. So you're moving away from any sort of hemolytic process, right? So any answer that might be hemolytic, you're not going to really go for. What is the most likely cause of a 2-week-old with a 9? Well, Crigler-Jack, rare. Biliary atresia, conjugated. So you can rule out some things right off the bat. Now, the hypothyroid, okay, but certainly the milk jaundice. This is a question that in truth you said, well, Dr. Stallworth, if you missed this, I missed this because they didn't tell me the patient was breastfeeding, okay? But they didn't tell you the patient wasn't breastfeeding either. Do you see the point? So if they were trying to that not be the answer, they would have probably said on cow's milk formula or something, trying to help you out to say that human milk jaundice isn't right. Because you know the most likely cause, you know that at that level of a 2-week-old, that's going to be the answer. But I can understand you looking at, now Gilbert's is indirect, again, rare. So I'm kind of have a little problem with that. They don't give you a family history because how do you get Gilbert's? Autosomal dominant. So again, classically, what's not here that you would expect because it's dominant, whereas in a recessive answer, you may not have a family history, right? But a dominant you should. If I'm getting it down to these two, that's what I'm trying to show you how you pick. Look at most, number 1, and then they didn't give me family history, number 2. Now you could argue, well, they didn't give me breastfeeding, and I got it. And so I can't just make it be without discussion. But at least I think if you're a good test taker, you would on par say, based on the way I look at that, I can see, Dr. Stallworth, that it should be the human milk jaundice. Okay. Number 11. Okay. A 2-year-old boy brought to your office for bloody abdominal pain and vomiting. He had a cold and now he's got the pain. And there are episodes of pain and he falls asleep. If you don't know, there's a great article on the CNS manifestations of intussusception. You have to understand that intussusception can present as a CNS manifestation. And that's really what they're asking here. And so the answer is, as you look at it, it's not what is the diagnosis. So if this was an example of a test question that was a long stem, if you look down at the bottom, what are they asking? They're going to ask for the test. You wouldn't get lost in reading the stem thinking, oh, I got the answer, it's going to be intussusception, because that's not what they're asking. They're asking the next level. What is the test that is going to manage? Now there's a key word, not diagnose, manage. And so if you're going to manage an intussusception, the management is best to have an air contrast enema because it diagnoses it and can treat it, correct? So that's the answer. Number 12, doing health care for 3-month-old, you observe jaundice. Well, liver is enlarged and firm. So incorporate the age, big, firm liver. This is not looking good. Here's the trick. Why did they tell you that the father has a family history of emphysema and they never smoked? Why is that there? Well, if nothing else, you would connect the dots depending on what the question is. Well, early emphysema is one of our diseases, cystic diseases. Classic alpha-1 antitrypsin gives you emphysema of the lungs, which is exactly what this question is asking and is exactly the answer. Alpha-1 antitrypsin, especially in this 3-month-old. Now remember that with alpha-1 antitrypsin deficiency, there's a whole host of phenotypes and genotypes, and they can present in an array of differences, correct? But the trick is that the liver comes first. The lungs come later. So you would not expect this patient to have lung disease at 3 months. It's the liver that gets them first. Okay, so the answer here is that. What about the other? Could you do a choledochal cyst? Yes, but that's a cyst in the biliary tract. That doesn't make the liver firm. Okay, we'll come to this next answer, biliary atresia. Once again, biliary atresia many times is kind of a cirrhotic liver. You know, it can be palpable, but it's going to have a problem. And the sweat test for CF, well, it could. I can't say it couldn't. I have to say there, but this is where if they give you the family history of emphysema, but don't give you a family history of, cystic fibrosis, you would have to ask yourself the question, why? And the why pushes you toward what they want for the answer, which is alpha-1. Your urine metabolic screen for Tarza, he'd be sicker before 3 months. I mean, the show would be over. Okay, 13, 4-year-old, blood in the toilet. Now notice some keywords here. Red blood, bright red blood. Red is bright red, okay? He has no pain. He's healthy. So intussusception doesn't fit those 3 criteria. Meckles could, I'm not saying he couldn't, but in that dark blood, not red blood. Rectal fissure, pain. Ulcerative colitis, pain, not well. By default, you're left over with a juvenile polyp. You see how this works? So I know this is a tough question. You may not know the answer, but this is where you go through answers that are not viable based on the stem of the question. And then you're left over with the only one that you may not know nothing about, but the others can't be right. Therefore, that is the right answer. You see how that works? So sometimes that's an approach. If you feel like you don't know the answer, I've never heard of this, well, let me go through the answers to see what it's not. And then I'm left over with potentially at least increasing the probability of me getting the answer right. And sometimes that's all you got. And as long as you increase your probability over the time course of a test, you'll have a number of these that'll allow you to pass the test. Okay? Or you're the most unlucky person in the world. Okay? All right. 14, 3-month-old, rectal bleeding, breastfed, weans cow's milk. Hello, we've been through this 1,000 times. Now notice this, if cost were an issue. I had to add that to this question because I didn't like this question, the way they answered it, and I'll tell you why. But you should have gotten this down to D or E. That's where you should have gotten. The other 3 don't make any sense, really, for this, okay? Because this is an MPA, right? No protein, right? So you're down to D and E. And either one of those answers would be clinically applicable, okay? But the cost of a soy protein is so much cheaper. But see, there's a 50% cross-reactivity with soy. So that's why you could say, I'm not going to take a chance at all. I'm going to go for the 100%er, and I'm just going to go straight to casein hydrolysate, which would be clinically relevant, very expensive. So that's why I put the disclaimer, if cost were an issue, what would you go with? And you'd go with soy to see what they did, recognizing that 50% are going to get well, but 50% aren't, and you may have to go to the casein. You understand that little dangling participle there? That makes all the difference in the world in terms of the answer. But at least if you knew it was D or E, don't beat yourself up, because practically either one of those. But if you didn't know that, then you are missing some key issues of milk protein allergy, database, classic presentation. You need to do some reading. All right, 15, 11-year-old begins vomiting shortly after receiving chemo. Again, this is a drug question. How does that drug work? You either know it or you don't. There's no point in dilly-dallying, right? And so this drug is a serotonin antagonist, and that's how it works, and that's the right answer. We could play the game all day, but it's a database. There's no point. There's no synthesis here. There's nothing more. It's just you have to know the pharmacology behind the medication, because they're not going to many times ask you the medication. That's A if B. They're going to ask you the C part. A, you figure out what the medication is, but that's not the answer. The answer is going to be, how does the medication pharmacologically work? You understand that point? So you can't just fall into the trap of, here's the drug. I have no idea how it works. I just know this is the drug. No, you got to know how it works, because that's going to be on the boards.
Stallworth,
Yes.
you have a question that says, what was the answer for number 13 and why?
Okay, well, we have to back up then, dear. I can't see 13.
Yes, dear.
Did I not go through that ad nauseum? Did I not do that, people in the room? Okay, what did they not specifically understand, because I went through that. I spent a lot of time on that question.
I'm not
Can
sure
you
it was
help?
Colin.
All right,
Colin, can you unmute?
unmute and tell me specifically, Colin, what you need. Earth to Colin.
Oh, sorry. So I was, I missed that real quick. It was,
Oh, I went through this one in depth because this is a very good question. This is where, you know, if you don't know the answer, when you're reading this, Colin, I don't expect you to perhaps know this answer of what the diagnosis is, okay? But this is the kind of question, if you go back, you can rule out 4 answers, therefore the leftover answer is correct. Red blood, bright red, not a Meckel's because that's dark. Rectal fissure, you would have pain. He hadn't had pain. Ulcerative colitis, you would be sick. He's healthy. Intussusception, you would have pain. There's no pain. There's no vomiting. There's no diarrhea. So by default, you're left over with the correct answer, which is juvenile polyp. Does that make sense? Does that give you what you need? Okay. Yeah, sometimes you have to do a question like that. When you read a question sometime and you go, I have no idea what this is. Well, look at the answers and tell me what it's not. And then you maybe can at least improve your chances. All right, go down, Whitney, again. I think we're on 16 or 17, sorry. Okay, 16. All right. Now this is kind of, did a lot of y'all put pyloric stenosis? Read this question just in the room, help me because I don't know the results. Okay. Did anybody put, I mean, I could see if you read this question quick, I could see you would be answering PS. Because you got a 2-month-old, non-bilious vomiting, and dehydrated, and it's hypochloremic, metabolic, or it doesn't give you the metabolic, yeah, little metabolic alkalosis. You know, I could see you easily saying that, right? And it's down there. But the trick is you've got to incorporate the radiolucent feeling defect in the pre-pyloric, not pyloric, pre-pyloric. Hence, the answer is going to be A, antral web. Antrum of the stomach is in the pre-pyloric area, right? Chronic intestinal pseudo-obstruction, that goes with, you know, weird sclerodermas and some funky stuff. Duodenal stenosis, I'm not sure I know what that is. Hirschsprung's disease, well, wait a minute here. We don't have constipation. We don't have, you know, it's more upper tract. So, and then pyloric stenosis, it can't be in the pre-pyloric area. Okay, 17, 14, growth failure, abdominal pain, diarrhea. He's got a little bit of a low hematocrit for a 14-year-old boy, and probably a girl too to some degree. White count's okay, SED rate's up a little. But look, go ahead and tell you what you suspect. You know, you wasted time trying to think through that. Of the following, physical finding goes likely with Crohn's versus ulcerative. So see, really, you don't even have to read the stem of this question. If the stem were, and you wanted to see what they ask, and you read that, oh, well, I don't need even, that's not even, all that other stuff doesn't even apply. And you just have to know what the physical exam finds. And you know that Crohn's is stem to stern, right? Lips to anus. Ulcerative colitis is just the colon. So therefore, perianal abscess is the answer, correct? For Crohn's. All right, all the others could potentially fit both of them. 18, not feeling like my fat, progressive falling asleep, nosebleeds, her skin color has changed, her liver's big, her spleen is palpable. So of the following that is most consistent with these findings, and this is a tough question because a couple of these could fit into there, and I would agree with that. But this kid, as she's coming in with this kind of the numbers that are before you, and this age and albumin being low, and I mean, she's got bad liver, you know, she's going into liver failure, okay? At 13. I mean, hep C doesn't go into liver failure at 13. But I can see how you might have been caught by answering that. Wilson's disease, well, okay. But Wilson's disease, you just don't go, you're at 13, your liver doesn't quit. That's not its presentation. So this is a fact that you've got an inflamed liver that's, for lack of a better term, almost dying on you. It's not producing albumin. It's not producing your coagulations. This is bad news. This is an autoimmune hepatitis. This is your classic adolescent girl who presents like this. That's an autoimmune hepatitis. And then you decide, is it ANA positive or negative, and could it be lupus or something else? But it's an autoimmune hepatitis. And this, always keep this in mind, but that's a bad liver that's going down the tubes. That could occur if they had put in there, she's been, if she had been taking some liver toxic drug, for example, but they don't give you that. 19, progressive intermittent cramping down, bilious, big word there, for the past 12 hours, okay? You had a laparotomy for Crohn's. Most favors that post-operative bowel obstruction. Okay. How many missed this? This is a basic, it's kind of like when I remember how I talked about doing a sacroiliitis exam. You either understand and know that part of your physical exam or not. And it's something you now should know, that you compress on either side, and if you've got pain, it's sacroiliac disease. Now, I'm not saying the cause of it yet. I'm just saying you got the sacroiliac joint involved. This is another one. In your classic world, now I understand in the clinical world it doesn't quite work like this, but in your classical world, hyperactive bowel sounds. I have an obstruction. I'm pushing against. Hypoactive. I have an ileus. I'm paralytic. Nothing's going on. So when you read this question and you understand with the bilious vomiting, he's probably got an obstruction. In fact, they tell you postoperative obstruction. The answer is going to be hyperactive bowel sounds, pushing against that obstruction. That's just a basic physical exam thing that you should work with every day. Unfortunately, in clinical practice, it doesn't always work that way, but on a test, that's what they expect. Okay. All right. 20, a two-year-old girl has biliary atresia and has the Kasai. Okay. And now she's vomited a cup full of blood that morning and she's pale. So we're in trouble. And if you've had bad biliary atresia, you know you've got liver failure. They tried to save it with the Kasai at 3 months of age. Now, you know, if you know the data about Kasai's, you need the procedure done within the first 6 weeks of life. The longer you go past that, the lack of efficacy the procedure's going. I'm not saying I wouldn't do it, but you're going to have some liver. That's why you don't want to miss this diagnosis. You cannot, and this is in your direct hyperbilirubinemia category, not indirect, direct. Okay, so this is the choledochal cyst, the alpha-1 antitrypsin, the biliary atresia, some inborn air metabolisms. They're all these indirect, and they're early on, and you don't want to miss them. And you know, direct hyperbiliary is always pathologic. You know that. But there's a timeline on a 6-week-old or a 2-month-old or a 3-month-old, and this is one of them. So she got the procedure a little late, so she's probably got some problems. Now she's got bleeding. The following that supports esophageal varices. Well, you know the pathology. Why do you have esophageal varices? You got portal hypertension. You got problems with the liver that's backing up to the spleen. And so you create blood vessels that become big because the blood can't get through. I know this is being very, pejorative in my description, but that's basically how it is. Don't make it harder than it is. And so you develop these collaterals. Remember the caput medusa that you may see on the skin, the esophageal varices. So the answer here is going to be the spleen extending 5 centimeters, which is promoting blockage of the blood flow, which is promoting vasculature elsewhere, varices, bright red blood. You get the drift. Okay, 21. Now, in fairness to you, well, I won't go into it. If anybody out there missed if they answered something else and you now don't understand why, please ask, because there's another answer there that you could have gotten caught on. But anyhow, I'll move on. 21, yes, Lee. 20, back up a minute, please, Whitney. Uh-huh. Uh-huh. That's exactly what I was going to go with. No. Yeah, no. This is exactly what I was referring to, that if you put that answer, because I can see that, okay? I can see that. Because, you know, I mean, that pro time is out a little bit, but is a 19 out enough to give you this pale bleeding? I mean, a pro time normal is what, 14 or 15? So a 19 ain't too bad. You know, if you gave me a 60, you what now? You're answering, you're looking at it from a clinical practice. You're not looking at it from a test taking. See, in a test taking, they're not going to do that. The 19 is a 19. Correct. 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 But not a bad answer. That's what I was just going to go. That was the answer I was going to, because I think it's good that you thought, well, wait a minute here. I understand liver. I understand vitamin K. I understand pro time being out. Bully for you. And I think that's great. And that's why I was going to go to. The problem is that number doesn't match the stem of the question. That makes sense? Okay. All right. 21, I think, is that where we are? Yeah. 21, 15-year-old, 3-week age of fatigue. She admits being, okay. Unprotected intercourse, and you got the drill. Her liver is, So she has got some numbers that are up. She's got some hepatitis going on with that number. The viral infection is associated with the highest risk for developing chronic cirrhosis, hepatitis. Again, this is a database question. You either know it or you don't, right? And what is it? Hep C. Yeah, Hep C. So again, not EB, not A, not E. If you got it to B, I got you. I mean, I hear you. That's not a bad answer, but the presentation, Hep B just doesn't present like that. That would be the, that would be your Hep C that's starting to go south. 22, 17-year-old brought to parents because they claim he looked yellow. He feels well and is active. Oh, his father had quote unquote acute hepatitis 12 years ago. Everything was pretty good. He's got an indirect mild. Other numbers are fine. He doesn't have Hep B. What is the answer? Well, once again, Crigler-Najjar type 2 is so bizarre and so rare. He doesn't have hepatitis because the liver enzymes are not up. So your A, B, and D come right off the page. Not to mention that Crigler-Najjar, I think, is a direct hyperbiliary. So this is indirect. So now you're down to primary sclerosing versus Gilbert's. Well, he's playing sports and he's happy as a lark. Does that sound like he's got cholangitis? So this is a Gilbert's, okay? Now, in fairness to you, they're hinting with this father's diagnosis, right? That the father probably had a viral illness, yes. And then his Gilbert's flared a little bit, right? So when they say, they really should have put, in my mind, for this fairness on the test, they should have put quotes around the acute hepatitis. In other words, the father's boy had acute hepatitis. Well, he did. He probably had a little hepatitic, but he probably had a viral illness. And, that's when a Gilbert's will flare. If you get a little viral illness, that's when you see a little bit more with the Gilbert's. Okay, that's what sets you up. Drugs. So otherwise, you do pretty darn well. I mean, it's no big deal. There are thoughts that I have Gilbert's, so there you go. Look at me. All right. 20. Don't look too close. All right, 23. 14-year-old obese girl presents with pain. All right, obese. Don't skip that word. Pain is under the back. Go through it. You can read it. Okay. Rectal exam is no tenderness or evidence of occult blood. So that may help you a little bit with some of those things, such as intussusception. That would go against that. And she's acute and bilious. Gastroenteritis, that's not bilious classically. Small bowel obstructions, bilious, so that's out. Where is no history of fever? Now, this is where you would say, okay, no history of fever and no history of dysuria. And I know you can have pilo, but if you start playing that game, no. You see, so this is another question where if you don't know the answer, but you go through the 5 answers of that, 4 become eliminated right off the bat, there's only 1 left. Now, in truth, this is acute pancreatitis because they can present this way. But let's just say you didn't know. But if you go through, like I said, those others with the words bilious or the words whatever, and the obese does set you up for pancreatitis, because they could have gallstones and they can have that whole biliary tract, pancreas, you get the drift. So the obese in and of itself could almost stand alone of the answers. For gastroenteritis, well, why did they say obese if it's gastroenteritis? Because there's nothing connecting that word. Do you see my point? So when you see a word like that you say, well, why are they saying that? It's because they are increasing the odds of you getting the answer right, hopefully. Okay. 24, 10-year-old presents with pain that was followed shortly after by vomiting, periumbilical, and this is your classic, and you know this. That appendicitis doesn't always present with right lower quadrant. It presents in the midline, having vomiting, maybe a little low-grade fever, and then it moves to the right lower quadrant. So the most likely is going to be appendicitis here for this patient, okay? Now notice they didn't say obese because there's acute pancreatitis there. And you know that a pancreatitis can occur in a non-obese person, but they didn't say obese. And so if you were trying to get yourself going there, you would have to say, and if none of the answers fit, I'm not saying I couldn't make that be it, but it's periumbilical. They don't talk about, and they say increased when the heel is struck. That's peritonitic. That's appendicitis. Don't try to make it be something bizarre, okay? 25-3 brought to the ED, history of blood in the stool for the past 12 hours. Okay, she's 3. Now she's got a low hematocrit. There's her PT is okay, Lee, at 12.5, 13. Her PTT is okay, so she doesn't have a coagulopathy, right? So you have to read this and say, what does she have? So what's the answer? What is this diagnosis? She's had, it's a Meckel's, right? And so what is your Meckel's scan? It's that pertechnetate scan, okay? So the answer is E here. Now, in fairness, you have to read this word diagnostic. You see that word? Because in fairness, in clinical practice, I could see you putting a nasogastric tube down. I mean, I'm not saying I couldn't, but that's not going to diagnose anything for you. And they're saying, what is the most appropriate diagnostic procedure or test or whatever? And you have to read it with the thing of this is the diagnosis. And then with that in mind, here's the most appropriate diagnostic test. 26, 4-year-old, abdominal pain for 3 weeks. He also is pale, quiet, soft abdomen. He's got guaiac positive stools. This isn't sounding good. His hematocrit's down. Other stuff looks okay, so he doesn't have cancer. Liver is not real impressive. Pancreas probably okay. What is the diagnostic procedure here? Well, you're back to what is your diagnosis? What? Okay, he could have IBD. Okay, fair, exactly. I think that's very fair. So what are you going to do? Remember, he's got vomiting. Yeah, so you're going to have to look at him, though, if you didn't have IBD, which would probably be a little more the other way, that what do you think he's got? He's got something going on in the upper tract. You don't know what it is. Is it an ulcer? Is it a mass? Is it, and he could have Crohn's disease, the stomach, esophagus. So he's going to get into esophago-gastroduodenal. You got to look and see what's going on here. This is not clear cut. And that's the diagnostic procedure to help you with location of the bleeding. And then further with that, the diagnosis, okay? And again, the stool is dark. In other words, not bright red. So not that that matters that much in this answers, but we know this is upper tract disease, right? He's 4, not 2. Could you have answered the Meckel's scan? Okay, what do you think? Well, he's a little, do you vomit with the Meckel's? Typically, no. That's just the dark stool and you come in pale. You may have some abdominal pain. Vomiting isn't a big deal with the Meckel's. So that's why that upper tract procedure study is what you want. Okay, how are we doing on time here? Okay, all right, next. 27, 5-month-old presents with, all right, and you know, persistent bilious 5-month-old, fall off a log. It's a volvulus, and you and I both know it. End of that story. I mean, pyloric non-bilious, pylo in a 5-month-old that comes in, no fever, no. Gastritis, that's not bilious. Appendicitis, a 5-month-old, no. I mean, this is pretty straightforward, volvulus. 28, 24 is brother and mother. The trick on this question is his height and weight are at the 50th percentile. His exam is normal. He's a happy camper. And when you see that, it's not going to be something real bad. And this is the fact that the kid's getting too much fructose. So the amount of juice the patient's drinking each day is too much. And that gives you those stools that are mushy in the carrot and everything. But the kid, you can't say, well, Dr. Stallworth, they're peas and carrots, so he's malabsorbing. Okay, got it. But then he wouldn't be at the 50th percentile. So you have to connect those dots. And so this is a classic, I'm drinking too much fructose, you know, cut down the juice. 29, oh, okie 6-week-old, thinks he looks yellow. It's, oh, here's our magic 6 weeks. Now we look at this and enzymes are from total bilious 7, direct is 3. We know the differential. I just went through the differential with you of direct hyperbilirubinemia, did I not? Holodococyst, annular pancreas, biliary atresia, alpha-1 antitrypsin. I mean, you got it, you know, and inborn metabolism. Okay, so the gallbladder is not visualized. So now you know it's an anatomical problem. And that's in the biliary tract. And so what is the next step? Well, what is the test for biliary atresia? It's a Decida scan. So that's A. Remember, they give you the dye, you watch it go through, and you see it empty into the intestine. And if you don't, why doesn't it? Because you've got biliary atresia. So an annular pancreas, it'll still get through. Choledochocyst, it'll get through. Alpha-1 antitrypsin, it'll eventually get through. You know, you got some liver, but it will process it and it'll get through. But biliary atresia, it won't, because it's atretic. There's no connector there. Okay, that's why the stools are acholic, right? White, because you don't have any of those things from the liver, the bilirubin coming through because it's atretic. Measurement of urine reducing substance. Why is it there? Why is that answer there? What would that be? The stem of the question, for you to answer that, what would the stem of the question's diagnosis be? In direct hyperbiliary, I just went through the big deals. What would be what is a urine reducing substance? Remember, it's a carbohydrate that doesn't have that has a reducing end, that OH and H that's put in the breeds. So that's your classic galactosemia, is a reducing sugar. Glucose is a reducing, maltose, mannose. The only non-reducing sugar is sucrose, because you take a glucose and you take a fructose and you connect those two ends together so there's not one flipping in the breeze, hence it's a non-reducing sugar. So here is, the problem is this kid's 6 week. He'd be dead if he had galactosemia, you know, because it presents 2 weeks and you're in trouble if you don't get it. So that's why that answer there. Sweat test, okay. All right, you can have liver and you can have a direct hyperbiliary, I got it. Lungs are clear. That, you know, you got to deal with that if you think that was it, you know, because the sweat test would be for CF. Hemoglobin electrophoresis, you know, that would be an indirect hyperbiliary, looking at a hemoglobinopathy, a hemolytic anemia. Echocardiographer, normal findings on cardiac exam. Why are you doing an echo when you see that in the stem of the question? So once again, this is one you can go back through if you can recognize what the answers traditionally represent, realize that's not the answer for the diagnosis, and then by default, you're left over with the Decida scan as the right answer. So even if you didn't know the Decida scan was for biliary atresia, if you went the other way, you see what I'm saying? Because those are the classics. But now if you didn't know urine reducing substance after galactosemia, then you're out in the storm with no shoes. Okay. Number 30, 2-year-old NEC, small bowel resection. I'll see this all the time. She's on parental nutrition. You think she's got small bowel. Okay. Now, this is basically looking at malabsorption from small bowel. They tell you that. The question is, what is the test for that? Okay. So you have to know that. What is the test for small bowel overgrowth of bacteria that can give you malabsorption? Well, it's a breath hydrogen, which is a carbohydrate, classic carbohydrate malabsorption. And so you can use that for lactose too, if you wanted to. Test it, because lactose is milk sugar. Okay, so that's the correct answer. If, and none of the others fit, 2+ reducing substances in the stool. Okay. What would that be? Well, that would be that she's malabsorbing a carbohydrate, right? But there are lots of reasons you do that. They want the answer to be specific for small bowel bacterial overgrowth, which is going to be an elevated breath hydrogen. Wonder if I'd have said elevated serum D-lactate. What would that say to you? Cecilia, Chelsea, what if I'd have said D-lactic acid and not L-lactic acid? That would have been a right answer. That'd been a right answer if I'd have put D down there, because that is another manifestation of bacterial overgrowth. L-lactic acid, the most common one, is your classic lactic acid when you're in lactic acidosis. Like if you get dehydrated and get metabolic acidosis, that's a lactic acid. It's an L-lactic acid. The D occurs with bacterial overgrowth. Okay, so, but I didn't put D, I put L, because that's not the right answer. But D would have been, so either one of those would have been fine had I put it there, right? So you got to know the difference between L and D. It's the L and D isomer. Remember L and D of, levo and dextro. Okay. All right, I think that's it. Okay, Whitney, any questions for the good of the group? I think,
There's no more.
okay. Group here, any questions? Okay, like I said, the nephrology will be put up. Whitney, when is that? Because I think that test is, the review is coming something like the 13th to 14th of April. There's only 2
The
weeks.
13th at 8 a.m.
13th at 8 a.m. And like I said, Dr. Holloman will have, when will the test be? I know I've done the test. I know you have it. When will
It'll be up next week.
It'll be up next week. So just pay attention. Okay. Hope this helped. All right. Bye.